Good afternoon and welcome to the Assembly Committee on Health and Human Services, and it is actually morning because we are getting a little bit started a little bit early. Would the Secretary please call the roll?
Assemblywoman Gonzalez, Assemblywoman Gorlow, Assemblyman Gray, Assemblyman Hafen, Assemblyman Hibbets, Assemblyman Koenig, Assemblywoman Newby, Assemblyman Nguyen, Assemblyman Orentlicher, Assemblywoman Taylor, Assemblywoman Thomas, Chair Peters.
And I am here. Thank you so much. I think we have everybody today. Wonderful. Thank you all for being here. A couple housekeeping items. First, we'd like to remind everybody to silence your electronic devices so we're not interrupting folks as they are presenting or speaking. Members of the public may testify in a variety of ways, all of which are listed on the agenda. You may also submit public comment in writing either in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, or up to 24 hours after the meeting's adjournment. If you wish to testify in person, please sign in by the door and leave a business card with your name and contact information. Even if you do not testify today, you may also wish to sign in so that we have a record of those who are interested in the bills we hear today. To ensure an orderly flow of discussion, I ask that all comments, questions, and responses go through me. Also, committee members, y'all know the drill. Please be recognized by me before you can speak. I ask our presenters on Zoom video call to leave your cameras off and microphones muted unless it is your turn to present or I direct a question to you. When testifying in person, please turn the microphone on to speak and off to listen so that we get a clean recording of our meeting for the secretaries. With that, we'll move on to our agenda. We have a work session, which we'll start with since we have everyone here today. We have two bills on the work session, SB 42 and SB 44. Make sure I'm not missing anybody or anything. All right, we're going to start with SB 42. Mr. Ashton.
Thank you, Chair Peters. For the record, Patrick Ashton, Research Division, LCB. Senate Bill 42 was heard on April 24th. It authorizes the use of county funds for medical assistance to indigent persons by the Board of County Commissioners of certain counties to provide an enhanced reimbursement rate or make supplemental payment to any public hospital in the county for hospital care provided to Medicaid recipients if authorized under any other supplemental payment program by the Federal Centers for Medicare and Medicaid Services. There were no amendments. Chair Peters.
Thank you. Are there any questions from the committee? No, thank you. I would accept a motion to do pass. Have a motion from Assemblyman Nguyen and a second from Assemblywoman Gonzalez. Is there any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. That motion passes. Thank you all so much. We'll move on to SB 44. Floor statement to Ms. Taylor. Thank you. SB 44, Mr. Ashton.
Thank you, Chair Peters. For the record, Patrick Ashton, Research Division, LCB. Senate Bill 44 was heard on April 24th. It transfers the State Program for Oral Health, the Advisory Committee on the State Program for Oral Health, and the duty to appoint the State Dental Health Officer and the State Public Health Dental Hygienist to the Department of Health and Human Services from various divisions within the department. Additionally, the bill revises certain educational and licensing requirements for the State Dental Health Officer and the State Public Health Dental Hygienist, and provides that persons holding these positions are no longer required to devote all their time to the business of their office. There were no amendments. Thank you, Chair.
Thank you. Are there any questions from the committee? Seeing none, I'd entertain a motion to do pass. Thank you. Thank you, Assemblyman Nguyen, and a second from Assemblywoman Taylor. Is there any discussion on the motion? Seeing none. Oh, yep, Assemblyman Gray.
Sorry, Madam Chair, I'll be a no with reservation.
Any other discussion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. Gray was opposed. The motion passes, and I would assign that to Assemblywoman Gonzalez. Thank you. All right, thank you all so much. We are done with work session, and we'll move on to our bills for today. We have 4 bills on the agenda, and we're going to take them in order. We'll start today with SB 4. I'll go ahead and open the bill hearing for Senate Bill 4. Sorry? Oh, 3. Sorry, 3 bills today. I know, it's a Friday. I am like, maybe not tracking quite as well as I should. Thanks for keeping me on track, guys. 3 bills today. We'll start with SB 4, which revises provisions governing certain programs to pay for prescription drugs, pharmaceutical services, and other benefits. Welcome to the committee. Please remember to state your name for the record. You may begin when you're ready.
Thank you. Good morning, Chair Peters, members of the Assembly Committee on Health and Human Services. We would like to thank you for the opportunity to present Senate Bill 4 today. And for the sake of time, I'm on some of the same flights as you all. We'll stick to the script. In fact, upon further review, maybe we'll really take a long time on Senate Bill 4. No. My name is Jeff Duncan. I'm an agency manager with the Nevada Aging and Disability Services Division, and I'm co-presenting today with one of my chiefs, Adrian Navarro, and we're so happy to be here. Was going to do a little ad lib, say boy howdy, because it's been a long time coming for us to have this opportunity to get this far, so I hope we do our bill well today. So Senate Bill 4 revises provisions governing certain programs to pay for prescription drugs, pharmaceutical services, and other benefits. The intent of the bill is to provide the department the ability to adapt to the ever-changing pharmaceutical landscape, which in turn will lead the prescription assistance program being more effective in addressing the pharmaceutical needs of a broader population of Nevadans. So the federal government has made many changes to the Medicare Part D over the past several years, which have positively impacted Medicare beneficiaries. With such changes occurring on the federal level, we as a state need to pivot, and which is why we're here today proposing these changes to the current senior and disability prescription program. Furthermore, Senate Bill 4 will allow for such changes by providing the ability for the program to support the most vulnerable Nevadans who are in need of prescription assistance rather than Medicare beneficiaries only. And so I'll now turn the presentation over to Ms. Navarro, who will walk you through highlights of the bill. In addition, we'll be happy to answer any questions. Thank you.
Thank you, Mr. Duncan. For the record, my name is Adrian Navarro, Social Services Chief with the Nevada Aging and Disability Services Division. In introducing Senate Bill 4 to the committee, I will first provide you a brief history of the Senior and Disability Prescription Assistance Program. The Senior Prescription Program was established during the 1999 legislative session. The Disability Prescription Program was added during the 2005 legislative session. This was in conjunction with the implementation of Medicare Part D in 2006. At that time, both the Senior Prescription Program and the Disability Prescription Program were designed to assist Medicare beneficiaries with the out-of-pocket costs of their prescription medications while in the Medicare Part D coverage gap, known as the donut hole, as well as assisting with the cost of their monthly Part D insurance premium. Since the establishment of Medicare Part D in 2006, multiple federal laws have passed, positively impacting the overall landscape of Medicare Part D. Most notably, the 2010 Affordable Care Act, which led over time to the final closure of the donut hole in 2020. The Bipartisan Budget Act of 2018, which required pharmaceutical companies to offer the same discounts to Medicare beneficiaries as they offer other insurance providers and pharmacies. And the Inflation Reduction Act of 2022, which will cap insulin copays, limit out-of-pocket drug costs, and allow for Medicare to negotiate drug pricing directly with drug manufacturers, to name just a few. As Medicare Part D has changed over time, similarly, it is important for the department to evaluate changes to the Senior and Disability Prescription Program. Utilization data alone demonstrates that change is necessary, with the average number of program members per month decreasing from 6,073 in state fiscal year 15 to 550 in state fiscal year 22. For this program to continue benefiting Nevadans, these legislative changes are being proposed. SB 4 will give the department the ability to adapt to federal and state policy changes and more effectively address the pharmaceutical needs of a broader population of Nevadans, while increasing equity and access to prescription medications for those Nevadans most in need. I will now walk the committee through each section of the bill and briefly highlight the proposed changes. Section 1 and Section 2 both remove references to repealed statutes. Section 3 removes the requirement that the funding be directly expended by the department. This will allow more flexibility in program design, allowing the department to also provide grants and enter into contracts or intergovernmental agreements to pay for or subsidize the cost of prescription drugs. Section 3 also removes the limitation that the funding must be used only to pay for benefits for seniors and persons with disabilities, and allows for this program to assist a broader population to include natural persons who are residents of Nevada and who meet the eligibility criteria established by the department. And finally, Section 3 revises the requirement of the department to submit a quarterly report concerning expenditures of the program to submitting an annual report. This aligns with other programs funded through the Fund for a Healthy Nevada under NRS 439-630. And lastly, Section 4 of the bill repeals statutes relating to the specific policies and procedures of the program. This too aligns with other programs funded through the Fund for a Healthy Nevada under NRS 439.630. In closing, we'd like to thank the committee for the opportunity to present Senate Bill 4, and we're happy to answer any questions that you might have.
Thank you so much. So folks, let me know if you have questions. I've got a couple that I will start with. So you mentioned the Healthy Nevada Fund. Is that how the program is funded? All right, I think I must have missed that at the beginning.
Adrienne Navarro, for the record, to you, Chair. Yes, the entire program is funded through the Fund for Healthy Nevada.
Thank you. And my second question relates to the change to the intergovernmental agreements and contracts. Can you talk a little bit about who may have participated in the program? Because it looks like a couple of the deleted sections, specifically 439660 and 439665, dealt with cooperation between state and local agencies and contracts. So who participated previously, if any, and then what do your partnerships you foresee them to look like, and with whom?
Adrienne Navarro, for the record, to you, Chair Peters. So the current program operates with contracts with Medicare Part D companies, providers throughout, national Medicare Part D providers. So we contract with them directly through ADSD, Aging and Disability Services Division. What we foresee looking at is expanding beyond Medicare Part D, and actually through the changes in this legislation, being able to potentially work with community partners, subawarding funding to community partners to assist with prescription assistance, potentially working with other government agencies and other contracted government entities in other states as well. So there's multiple different options that we could look at as we look at making changes to this program to most meet the needs of those in Nevada. And the intent of this legislation is really to open up that statute to be able to do so.
Yeah, I could see that benefiting some of our local programs in a variety of ways, at least up in northern Nevada. Okay, I have a couple of other questions. We'll start with Assemblywoman Taylor.
Thank you, Chair. Good morning, and thank you for the presentation. Just a question informationally. You mentioned some really dramatic decreases. That one. Can you talk a little bit about? I know we're talking about because some of the changes federally that have had an impact, but that was pretty dramatic. 6,000 and some change down to 500 and some change. Can you talk a little bit about that?
Adrienne Navarro, for the record, through you, Chair Peters, to you, Assemblywoman Taylor.
Please feel free to go directly to the member.
Thank you. Yes, so those were dramatic changes. The program has dramatically changed over time, and it really has been impacted on that federal level of the changes with Medicare Part D. on the federal level and what Medicare Part D provides, and also the introduction of Medicare Advantage plans. So many Medicare Advantage plans do not have a monthly premium for their Medicare Part D portion of their entire package, I guess I'll say. So with that, we then do not have a service to provide to those individuals in need, because what we're doing is subsidizing the cost of a Medicare Part D premium with this program right now. So we're really looking at trying to expand and how can we assist people with the cost of their prescription medications again and go back to that. So that's where we've really seen the decrease in the number of people utilizing the program, because not as many have a Medicare Part D premium anymore because of the beneficial, again, those beneficial changes on the federal level are really potentially now allowing us to utilize these Healthy Nevada funds to now look at what are the needs in Nevada on our state level and how can we best utilize those funds.
Thank you very much. And my mom lives with me, so I believe it or not, I actually followed all of that. Right, all of that with D and Advantage and all of that. So really, the proliferation of Advantage programs, of Medicare Advantage programs have really made it so we don't need as much. Basically, as many people don't need this because fewer people need Part D, because prescription drug care is taken care of over here. So I say that to say that thank you for saying, hey, then how else can we use these funds to help those seniors, right, that need it, and now we can help them pay for their prescription drugs, and then how can we expand it to help some others? So thank you for looking for ways, what else can we do to help more Nevadans? So thank you so much, I appreciate that. Thank you, Chair.
I have Assemblyman Ornlicker next. Please go ahead.
Thank you, Chair, and thank you for the presentation. So I understand the logic, and it is good if we're not needing the money for people who used to get it to expand. I'm just curious how this plays out with the overall fund. These are the tobacco settlement dollars. One of the concerns is that we don't do enough for public health. And so I could see this playing out in a few ways. One is the legislature decides each year how we're going to allocate. And you're just saying when you allocate whatever you're allocating for prescription drugs, give us more flexibility so we use them as effectively. But this doesn't say anything about whether the money's going to go to prevention, drugs. Is that correct? That this is only as we decide every 2 years how to just allocate the funds, we can use whatever dollars go to prescription drugs more effectively. Is that the way to read this?
Adrienne Navarro for the record, to you, Assemblyman. Yes, that is correct. So it would, whatever money is allocated from the Funds for Healthy Nevada to this specific program under this specific statute is what we're talking about. So it's about looking at how to utilize those allocated funds to best assist those in Nevada with their prescription needs.
Thank you. Are there other questions from the committee? Yep, as Assemblywoman Thomas.
Good afternoon, Madam Chair, and thank you so much. Thank you for this presentation. My question actually has to do with your amendment. And, you know, I guess it's wordsmithing, whatever. But I'm not understanding section 3 when we, on line 30, when we speak of natural persons. I was wondering how come you use that natural in there? Are we looking at natural citizens? Are we looking at, you know, I would think that persons would suffice. So I was just wondering why natural?
We have Mr. Eric Robbins willing to weigh in from legal. Please go ahead, Mr. Robbins.
Eric Robbins, LCB Legal, for the record. So in the preliminary chapter of NRS, the term persons is defined to include both actual human beings as well as basically in any corporate or other non-governmental entity. So in order to distinguish when we are just talking about individual human beings, we use the term natural person rather than person.
I had a similar question related to the resident criteria in that same section. Do you guys have an existing criteria for what qualifies as a resident that you already use, or is that something you would develop in the regulations?
Adrienne Navarro for the record, to you, Chair Peters. Yes, we do have an existing policy. However, we would be looking at revising that as well to open that up as much as we can. There's a current requirement of a 1 year being a resident in Nevada for 1 year. So there's potential of looking at that a bit further as well to within regulation to expand that.
We look forward to seeing what you come up with. We were just talking the other day about the potential for some discretion in the determination of whether someone's intent is to reside in the state of Nevada versus their actual residential criteria. And especially when we're offering social services in the beginning of someone's move to the state, it can be really helpful and uplifting just generally for their livelihood in our community to have those services available initially. So I look forward to seeing what you guys come up with that. All right, other questions? Seeing none, we will move into testimony. We will start here in Carson City and Las Vegas with support testimony on Senate Bill 4. I would invite those who would like to provide support testimony to the tables. Just a reminder, please state your name for the record before you begin. You may proceed.
Good morning, Chair and members of the committee. For the record, my name is Annette Magnus, and I'm the Executive Director of Battle War in Progress, and I'm here today in support of SB 4. We hope you will pass this critical measure. Thank you.
Thank you so much. Seeing no one else coming to the tables in support, I will go to the phones. BPS, is there anyone on the phone line to provide support testimony on Senate Bill 4?
Chair, there are no callers at this time.
Thank you. We'll move into opposition testimony and their physical locations. Is there anyone who'd like to provide opposition testimony in Carson City or Las Vegas? Seeing none, BPS, is there anyone on the public line for opposition testimony on Senate Bill 4?
Chair, there are no callers at this time.
We'll move into neutral testimony. Is there anyone in Carson City or Las Vegas to provide neutral testimony today? Seeing none, BPS, is there anyone on the public line to provide neutral testimony on Senate Bill 4?
Chair, there are no callers at this time.
Thank you so much. Would you like some, nope, we're waiving closing remarks, and that will take us to the end of our hearing for Senate Bill 4. Thank you all for being here. We'll move into Senate Bill 43, which makes various changes relating to services for aging persons and persons with disabilities. Please remember to state your name for the record when you speak. You may begin when you're ready.
Good morning again. Jeff Duncan for the record. Good morning to the committee, Chair Peters. Thank you for having us today. I will be co-presenting today with my wonderful administrator, Dina Schmidt. Senate Bill 4 makes various changes to services for aging persons and persons with disabilities. We've affectionately called this our agency cleanup bill. And so the intent of the bill is to clean up language in NRS 427A related to various public bodies, strategic planning, and the Community Advocate Program. This language will help us clarify various duties of the Aging and Disability Services Division and our public bodies. So now I'll walk through each section of the bill and walk the committee through the changes we're proposing. So Section 1 of this bill authorizes the governor to appoint members to the Commission on Aging who are employees or officers of city and county governments, expanding the language from officers of these governments to include employees of the city and county governments, will help to fill vacancies in the commission and ensure representation of city and county government is included in the work of the commission. Then Section 2 of this bill removes reference to outdated one-time funding and clarifies the duties of the division in relation to the strategic plan for people with disabilities for more transparency. Apologize, I'm going to take my glasses off because I get when I look up close. Then Section 3 of the bill expands language related to the duties of the Commission on Services with People with Disabilities. Specifically, it adds a requirement to coordinate efforts with the State Independent Living Council in line with the State Independent Living Plan. The State Independent Living Council, we call it SILC, is a federally mandated council made up of a majority of people with disabilities who are responsible for advocating for the needs of people with disabilities in the state, specific to independent living. This language will help to ensure collaboration between the two public bodies and reduce duplication of efforts. Then in sections 4 and 5 of the bill, shortens the name of the Office of Community Advocates for Elder Rights. In the 2017 session, the duties of the Office of Community Advocates was expanded to include people with disabilities, and we will have to better reflect the broader population that our agency serves. So this change just removes the term elder rights from the title to be representative of the previous changes approved in the statute. And then finally, in Section 6 of the bill, this broadens the duties of the commission for people who are deaf and hard of hearing related to the strategic plan. Specifically, the revised language gives the commission the power to develop a state plan for serving people who are deaf, hard of hearing, and speech impaired, rather than a strategic plan specific to services of the division. This allows the commission to develop a comprehensive recommendations for services for their target population beyond those under the purview of our agency and is in line with their current priorities. So in closing, we'd like to thank the committee for the opportunity to submit or present on Senate Bill 43, and we'd be happy to answer any questions. Thank you.
Thank you. I have a question from Assemblyman Nguyen. Please go ahead.
Thank you, Madam Chair, and thank you for bringing this together. I feel like we've done a lot of cleanup this session, and I feel like we are really going forward in ensuring that we look at everything that needs to be addressed, some of the things that have been in statute for a while that needs to really look at how our state has moved in terms of population and demographic. So with that question, if you had been watching this committee since the start of the session, you're probably going to know what I'm about to ask. And so that is going to be consistent with my line of questions are in making these changes to ensure that you have a very diverse pool of members that could create a better report and recommendation of this community. Where are we at on adding qualified member who come from household that speak more than one language? Because as our state grows in that diversity and the aging community will need those input from household with more than one language so that we can accommodate these cultural needs as we prepare to support them in the long run. So hopefully one of you could address that. Thank you.
Dina Schmidt for the record, and thank you for the question. So a couple of items. Many of these boards and commissions, some are governor appointed, some are director appointed. So where we have the ability to recruit and look at members, we are definitely looking at trying to identify folks that may be dual language or English may not be their first language. As far as the materials and the meetings and that type of stuff, making it accessible, we have completed our language access plan in our agency and identified 4 or 5 areas where we are working towards making sure that all the materials that we issue both on our website and in writing anywhere are more inclusive of multiple languages. So I hope that helps.
Follow-up, Chair? Thank you. So if that was the intent for you all to get more diversity in the body that advises the division, if you're saying that the director is probably already ahead of the game, would it be more helpful to add the intent for the governor's council to be more reflective of this need? Because if it's not said in there, and I know we all have good intentions, sometimes it gets forgotten just because there's so many things are out there. I'm just trying to see if we could put that in statute in terms of even the governor's council to ensure that this population is not left behind.
And Dina Schmidt, for the record, whether, I think that both bodies do a very good job. I think we're trying, we have a really close relationship with the group, the individual that does processes the appointments, and we communicate with them a lot of times about what is missing in our current membership so that when they get applicants in, they're looking for whatever it is that might be missing on the board. So we try to do a good job of communicating them whenever we have openings of the type of individuals we're looking for, and we'll continue to do that. So it's our intent to continue to do that, whether it's in statute or not.
Last quick follow-up, Chair. Thank you. So do you know offhand if the current makeup of the body has any members that does come from a bilingual household? And if you don't have that right now, you can get that to me. But I think I just want to put it out there on public record that we are looking at this, and we are going to be very, very intentional in ensuring that this happens, and that we don't just talk about it and we do it. And I know with Health and Human Services, you all are amazing in your work, and there's a lot of work to do. So I appreciate all of your efforts. And, in my past role working with you and others on HHS team, it's always been very innovative. So I appreciate that. I just want to make sure that we put this on public record and we intentionally add these individuals into the makeup of these advisory groups. Thank you, Chair.
Thank you for the question. Any other questions from the committee? I have one regarding the first section change to makeup of the committee to include employee rather than just an officer. So I guess my question is, rather than an officer or their designee, we included an officer or employee. Can you describe why we picked that language?
Dina Schmidt, for the record. So in my role as the administrator, I serve currently as the chair of the Commission on Aging, and we have always had a robust membership, but we've always struggled to get city or county entities in participation. One of the barriers has been the language that's in here, and it says governing body. So oftentimes those individuals that qualify under that aren't available, but the folks that work in the government bodies would be available and are very interested in joining the commission. So we're just hopeful. We changed it to employees so that it could be as broad as possible to get the city and the county's view on the issues that we cover in the Commission on Aging.
I just wonder about the difference between that and requiring that a member of the governing body designate somebody from their office so that there's at least some kind of hierarchy and decision making of the person who's included in the committee, that their governing body knows that they're there, right? Rather than being just appointed by happenstance of being an employee of that. And I don't know if, Mr. Robbins, there's a legal difference really between a designee and an employee that would cause problems, but this is the first time I've seen an employee rather than a designee, so I guess I'm just curious if it makes much of a difference.
Eric Robbins, LCB Legal, for the record, there's not a legal reason that it says one or the other, at least as far as our drafting goes. This was kind of a policy change requested by the agency, and so I feel like they're probably better fit to explain that.
And Dina Schmidt, for the record, it was really, the intent was just to make it as broad as possible. So if there's a desire to have it designee, we wouldn't be opposed to it. Like I say, we just would like to make sure that we have the voice of the city and the county entities involved. And it's been very difficult to get people willing and able to participate.
Okay, so I think I would make a suggestion that we look at potentially changing this to an officer or their designee who is an employee. And that way we keep it in that group so we're not getting someone from outside of the agency in, but that the officer at least knows they're there. and we will work on that amendment and contact you guys on that piece. Are there any other questions from the committee before we move into testimony? Seeing none, thank you for the presentation. We will move into testimony on Senate Bill 43. We will first take support testimony in our physical locations and then move to the phones. Is there anyone in Carson City who'd like to provide support testimony on Senate Bill 43? Seeing no one in Carson City, no one in Las Vegas. BPS, is there anyone on the phone lines to provide support testimony on Senate Bill 43?
Chair, there are no callers at this time.
Thank you. We'll move into opposition testimony. Is there anyone in Carson City or Las Vegas to provide opposition testimony on Senate Bill 43? Seeing none, I would move to the phones. BPS, is there anyone on the public line to provide opposition testimony on Senate Bill 43?
Chair, there are no callers to provide testimony at this time.
Thank you. We'll move into neutral testimony. Is there anyone in Carson City or Las Vegas who'd like to provide neutral testimony on Senate Bill 43? Seeing none, BPS, is there anyone on the public line to provide testimony, neutral testimony on Senate Bill 43?
Chair, there are no callers at this time.
Thank you so much. I will ask if there's closing remarks. So, all right. Thank you so much for being here today. That closes out the hearing on Senate Bill 43, and we will move on to our final hearing today on Senate Bill 192. I would invite the presenters up. Senate Bill 192 revises provisions relating to county hospitals. Please remember to state your name for the record. You may begin when you're ready.
Good morning. Nice to see you all again. Mason Van Houweling, Chief Executive Officer of University Medical Center. And we're here to discuss Senate Bill 192. This bill supports UMC's mission to provide the highest level of care in our state and to provide our patients, and while ensuring quality and meeting our goal of trusted stewards of the taxpayer dollars. This bill offers several key improvements, actually 3, and I'm going to take you through those 3 improvements here. First, it codifies the UMC Governing Board in Nevada Revised Statutes, NRS, which currently refers to the board as an advisory board. In 2013, Clark County Commissioners, with their foresight, recognized the importance of having dedicated community members with a certain skill set and special knowledge to really help turn around UMC since 2014, and to provide oversight and daily management of hospital operations. The board was actually created via county ordinance. Clark County members, commissioners actually appoint the governing board at UMC, and UMC's Clark County commissioners ultimately serve as the board of trustees of the hospital. The board consists of 9 members. We have a governing board, and then within the governing board, there's 4 subcommittees: a quality committee, an audit and finance committee, an HR, and a strategic committee. And they meet monthly, sometimes more than monthly, all coming together to help support the operations at UMC. Next, as you all are well aware, and this committee understands the complex nature around healthcare laws and regulations, and it's incredibly constantly evolving, obviously. The second intent of SB 192 is meant to address the complex, unique issues around public hospitals face around the regulatory environment. UMC would like the ability to have frank and open dialogue with our board members, both our trustees and our governing board leaders. In fact, our licensing boards and regulatory accreditation standards, CMS and others, require us to ensure that our boards are fully informed and making difficult decisions. Within the ability to have these private deliberations under Nevada laws, procedures, and statutes often sometimes conflict. Furthermore, it can lead to delays in informing the board timely. And we would like to actually take proactive measures that can serve to improve the quality and patient care that I've been discussing. To be clear, this bill does not allow the governing board or the trustees or any public hospital in the state to take any action or make decisions in closed session. And recognizing the importance of allowing public hospital boards to conduct certain proceedings in closed session, other states have also authorized the boards of county hospitals to enter in a closed session for very similar reasons that are outlined in SB 192. Nevada law also currently authorizes other public boards and bodies to go into closed session. This bill will allow public hospitals and governing boards in Nevada to fulfill an essential function and proactively address federal and state requirements, as well as potential legal and regulatory issues. This bill is not against transparency, does not create any new privilege, expand existing privileges, or allow any action to be taken in a closed session. This is merely to address and the ability to deliberate and have discussions with our board members. All matters of voting will occur in open session in accordance with all existing requirements. So, and then finally, the last piece of the bill will allow the employment of dentists. This will expand the language to include dentists. Let me give you an example. And probably every day, every night in our state, somebody ends up in an emergency room that has a dental emergency. Once we've established emergency medicine and stabilized the patient, often our doctors throughout the state will just prescribe a pain medication and try to get them through the next day until they can get to their dentist. As we all know, it's very difficult to get into dentists, especially on Fridays. I know with my own, it's difficult. So what we would like to do is really proactively take care of the patients that enter into our emergency room. Obviously, a dental emergency doesn't raise the level of a stroke or a cardiac arrest or a gunshot wound at UMC, but often patients have to wait for hours waiting to seek out care or may not have access to a dentist, quite frankly. So what we would like to do is allow that patient to see a dentist within our organization very quickly, either that day or get him into the next morning to be able to start taking care of that dental emergency. Again, throughout our state, doctors are just writing scripts and getting them through the pain and getting them through the dentist. So we would like to use our resources to be able to provide some type of care, either on site or even via telemedicine if we need to, via our quick cares and primary care offices. So again, I think it's appropriate too to try to minimize the cost to the patient. So in closing, UMC has always worked with various stakeholders to address the concerns and always willing to listen to find a suitable path forward for the best patient care. My thanks to the Nevada Press Association, the Nevada Justice Association, and also the Nevada Rural Health Partners. And Mr. Osborne will also speak a little bit more about how this bill not only impacts UMC, but also all the public hospitals throughout the state. So, Madam Chair, if you don't mind, if I can turn it over to my colleague here.
Please go ahead.
Thank you, Chair Peters, members of the committee for hearing Senate Bill 192, Blaine Osborne, Nevada Rural Hospital Partners, for the record. And I want to thank our friends at UMC for including us with this proposed amendment, and to further clarify that when we're talking about county hospitals, we also have to remember our county hospital districts that are also in NRS 450. Currently, UMC is the only county hospital, but we have 7 county hospital districts that have hospitals. Those are Humboldt County, Lander County, Lincoln County, Mineral County, Pershing County, South Lyon, and White Pine County. Our county hospital districts' governing boards have to meet all the same requirements with the open meeting law as with UMC. There are some inconsistencies throughout Chapter 450 that we've recognized need to be cleaned up and addressed, hopefully in the next legislative session. So we appreciate not creating another one here with this bill. Really appreciate and urge your support and would stand for any questions. Thank you.
Thank you for the presentation. This is an interesting topic area. I have a couple of questions from folks, and we'll start with Assemblyman Nguyen.
Thank you, Madam Chair. And I think, I'm familiar with this particular ask because, I am also part of many nonprofits over the year. In terms of having this particular ask is so that things that could be discussed in your closed meeting, that's what we call it, closed sessions, are more of a sensitive nature, right? And that creates a level of fiduciary responsibility to these board members. That is the whole intent. And those are only for discussion. And I just want to make sure that we put it out there. Those are just for purely discussion. Any action that is derived from those discussion will have to be taken in the public setting. Is that correct?
Chair Peters, through you, I'm assuming the answer, but I just want to make sure I have the approval. Yes, sir, absolutely. Again, a lot of the discussions are very high level, often in public, and we want to get more granular. Sometimes it's aggregated. And again, sometimes we're talking about conduct and performance related to physicians. So again, everything will always be done in an open session, but allows us to have those very frank conversations to really get in. And as you know, HIPAA, there's a lot of HIPAA rules and regulations around. So again, this will allow us to really allow the board to be fully informed and have that open dialogue. Again, I on the record as well, these will always be done in open sessions when there's decisions to be made or final deliberations.
Follow-up, Chair. And so 5 years was the time that, you know, it's in the bill right now. Was that standard across the board in terms of other practices around the country, or that's just the number that we came up here in Nevada?
Yes, sir. I can at least talk to you about what our previous bills as far as going into closed session and others is typically, again, everything's recorded and notes and transcripts, and after 5 years they will be released, if not sooner. If a private or public decision is actually made, that will be released sooner. So it's consistent what we've seen at UMC, but also throughout the state.
Just to clarify, so not based on any other states' best practices. This is just purely based on Nevada's best practices?
Sir, if you don't mind, I could call a friend behind me, and if you don't mind, do you mind if our general counsel comes up, Chair?
Go ahead. Just a reminder to state your name for the record when you speak, so we have that in our minutes.
Sure. Susan Pitts, General Counsel of UMC, for the record. So 5 years was an existing law. So in NRS 450, there was the ability to go into closed session for other issues previously. So we've just kept that 5-year standard, but I'm not aware that any other states, what they have in the way of keeping those public for a period of time.
Great. Thank you for the clarity, and thank you for the phone a friend. It's always welcome in this committee, but you have to ask the boss behind here, the chair. She has to approve it. But thank you for the answer, and thank you, Chair.
Thank you, and I know Ms. Pitt's work, and she's phenomenal. I'm glad she's on our team. So, thank you, Susan.
I have Assemblywoman Newby next.
Thank you, Madam Chairwoman, and it's good to see you all. I remember when the governing board legislation went through initially, and I'm so glad to see that it's working so well. I wanted to dive in a little bit more on the closed sessions, just because I've been party to a number of those, and so I just wanted you to maybe talk a little bit more about what actually happens, and sort of like the steps in terms of recessing, then going into the room, starting the recording, having the discussions. Could, just for my colleagues' information, could you talk a little bit more about sort of the nitty-gritty of how that works?
Yes, ma'am, and I will actually defer to Ms. Pitts on this one, if you don't mind, Chair. She ensures that we make sure we follow all NRS and open meeting laws and our closed sessions, so properly noticing and making sure that everything is to the standard. So, Ms. Pitts, I'll turn it over to you.
Sure. Susan Pitts, General Counsel for UMC, for the record. So yes, you would properly notice in the agenda that the board would be going into closed session. Then there is a motion to go into closed session. There would be no action in closed session. So in the closed session, you have a discussion with the board. You're able to have all members of the board, as opposed to perhaps a briefing, a one-off discussion outside of the open meeting law. So this allows them to go into closed session to have a discussion with each other. Only a discussion, no actions can be taken. If an action was to have to be taken that day and not at some subsequent meeting, many times it's, a subsequent meeting, it comes back and it's on the open session, and that's where the action is taken. But in the closed session, if it was decided it needed to be for some emergency reason decided that day, they would adjourn the closed session, reopen the open session, and take the action there. I hope that answers the question.
Can you talk a little bit about so if you go into closed session, you have a discussion, and then when you come out to open session to make a decision, what do you cover about what the discussion in closed session looked like that resulted in potentially a decision that's now in the public space? Is there best practices or policy in place that express it, where you have to talk a little bit about like how the decision came to be while the discussion happened behind closed doors.
Susan Pitts, General Counsel for the record. So if I'm understanding your question, if you could just repeat a little bit, what do we have to explain when we come out of closed session?
Yeah, if the discussion in closed session ends up resulting in a decision that's made in the open session.
Okay, so, you know, and honestly, I haven't had that experience. Usually, typically, it's more to inform the board and to have a discussion. So there's not a whole lot of times I've experienced where you have to immediately come into open session and discuss it there. But if you were doing that, obviously you'd have to give context around what the matter you were discussing is. Say it was a provider matter where you're coming out to take action, unfortunately, an action against a provider. You would certainly have to give the context. You would have to explain what the case is about or what the issue was about, and then you'd have to explain the decisions. What you wouldn't be explaining, for example, is if there was very specific information regarding a provider or a patient. Certainly that isn't meant to be shared in a public setting because that, you know, patients shouldn't have their information clearly talked about in an open meeting.
Yeah, I think I understand the patient piece, and then I have had the privilege this session to dive into the Board of Medical Examiners process with providers, and most of that is kept very, very tight. So we're not exposing folks, our providers, to potential issues with their. Oh my goodness! What's so Friday, you guys? With their reputations, pending those discussions and the internal workings. So I understand those two pieces, and I think they're important parts of the process for really dealing with those who are in the healthcare space. It's interesting that we're talking about this, and it feels like to me for kind of the first time. Given that there are these existing scenarios in place in which we are very protective of people's information. Anyways, I have a couple of other questions.
Peters,
Yes,
just
please go ahead.
add a little bit more. If again, as Ms. Pitts, we've not had to do that. I think not saying that won't happen, but obviously, if there's something with imminent patient harm, I think that would be one that we need to do something today. But as Ms. Pitts noticed and informed you that. Typically, those get agendized on a regular schedule. So if it's not a life or death type of situation, it will go through the normal process. And as she mentioned, context would be put around that. But we have not had to do that since I've been there and going on close to 10 years. And I think only with direct patient harm that we would see some imminent danger. But if that gives you any comfort.
Thank you.
Thank you.
Assemblyman Koenig.
Thank you, Chair. So I want to touch on a little about the part about employing dentists. I'm coming from the perspective as an optometrist, so we're kind of cousins, but we're not exactly the same. I know in the state of Nevada, there's some pretty strict laws on employing an optometrist, just like, every Costco and Walmart, it's the independent doctor next to Costco or whatever, they're not employed, they're independent contractors. Not sure why none of those places have dental practices. I've never figured that out. Why you go to Costco and get your eyes checked, but you can't get your teeth fixed. But anyways, is there any provisions as far as employing a dentist? I think you'd have a hard time employing an optometrist. There'd have to be a contract. Do dentists have the same rules where they can't be employed? They'd have to be a contract, or they might not have any of those rules, and you can just flat have them as an employee. Can just clear that up for me?
Yes, sir. Great question. Appreciate what you do. Yes, in the state of Nevada, there's very clear guidance around the corporate practice of medicine of dentistry, and so that's what we're trying to do, and to ensure that we respect that rule here in the state of Nevada. So we are looking for that exception to be able to to hire a dentist and do exactly what we said we would like to do, is be able to provide that service, an emergency room setting, to be able to get them to the right care much sooner, either that day or next day. So again, we're getting guidance and clearance to be able to do that in the state of Nevada. But again, the state of Nevada has very clear corporate practice of dentistry rules, and so this would allow us to do that. Just for a little comfort, I've talked with our dental board here in the state, also our state dental officer. All think it's a great idea and supportive of it too. So.
Thank you. As long as they're supportive of it, I would have almost liked to have had someone from them saying, yes, we're okay with being employed, but, because this right here could be a pretty big shift, where all of a sudden now they can be employed. I don't know. Hospitals, yes. Costco, still no. I mean, it'd be interesting to see what the dental board said, but that, as long as you talk to them and work things out with them, then thank you for your answer.
And just to add a little bit, obviously this UMC is trying to fill a gap in the community like we always have. And so I don't know if a lot of the hospitals in the community are going to go out and hire a lot of dentists, quite frankly, and put them in the emergency rooms or co-located with the emergency room. But again, just trying to give great patient care to our patients that show up at our doors and not have to wait for days on end and suffer.
Well, I know I've said this before. I didn't realize how important oral health was until I was pregnant, and like the impact your oral health has on the rest of your just overall well-being, even your mental health, can be huge. So I had another question related to this before we move on to other committee questions. So I don't know very much about the inner workings of dental reimbursement through Medicaid, but I do know that there's some limitations on it, and have had conversations with FQHCs who have struggled with providing adult dental in a facility where Medicaid is, where they are providing care to Medicaid patients. I don't, like I said, know the ins and outs of it, but did you guys go through the process of making sure that it's in compliance with all of the funding streams that come in through your facility? I just want to make sure there's no inadvertent crosswise there that we may have to come back and fix.
Yes, Chair Peters. So for years, I've been talking to the dental community, especially our state dental officer, who's sometimes been located down in Las Vegas and sometimes up in Carson. So we've had conversations in the past, and they've actually tried to work together on providing even online care or telemedicine through some of the state managed Medicaid programs. Some of the problems is we've hit this corporate practice of dentistry to be able to pursue some of those insurers to be able to get, because if we would have gone to them and filled out applications, they would have kicked it back and said corporate practice of medicine. So again, that's why we're kind of here. They seemed very supportive to be able to provide some of that care, and then we would go out and panel our dentists that we hire to be on those plans. But until we can get past the corporate practice of dentistry and get that exception, we cannot get them impaneled. But we've got to take this step first, but I don't see any problems with getting reimbursed moving forward. Because right now, unfortunately, the system is paying a much higher level for the ER visits, and as you all know, the ER is the most expensive level of care. So what we want to do is shift that over and provide a better option for all payers.
Thank you for that answer. And I might follow up with you on that piece because I'm just curious how it all works. I have 2 more questions on my list, y'all. Okay, 3 more questions on my list. We'll start with Assemblywoman Taylor. Please go ahead.
Thank you, Chair, and thank you for being here. One, thank you for the presentation, and there's so many things I like about this because it's about patient care. Specifically, I like the addition of a dentist. It makes sense. I mean, something happens on a Saturday night, you aren't going to get in. You won't even get in Monday. Let's just be honest about that. But you certainly aren't going to get in before a weekday. So I mean, I think that makes sense, with the exception and so on. I have a question about, you said you spoke with the press association in terms of the transparency. That's always a question, right? About and I know in Nevada we have some of the most restrictive open meeting laws in the country. I used to be on the school board, so I know this. And so, but there's that balance, right, between the public and so on. So thank you for speaking with them, and at least getting them to the place of neutral. But I do have this one question about the closed sessions, right? Certainly understand the need for it, and it's from the amendment. So thank you for providing that. Although the writing's a little small, maybe I'm the only one that thinks it's a little small. Just saying. Yeah, says the eye doctor,
Yeah,
right? All right, just quickly though, down we get down to is number 3. I'm just going to call that sub 3, sub D 1. Typically, when you go into an open session, there, right, the Nevada Open Meeting Law, and I'm surprised you didn't have that in here before, that you can look at the misconduct, I call it the character, the conduct, and the competence, right? It's interesting you didn't have that, so it's in blue, so you're adding it, so that's good. That's where that should happen. My question is about sub 1 under that D, is the compliance of the hospital with all laws and so on. I'm thinking that's something the public would be interested in. Talk to me about that a little bit. If there is some lack of compliance as it comes down to the regulations or rulemaking around Medicare or Medicaid, is that not something we want? Help me understand why that should be. I get it, and there's certainly some things that should be closed session, absolutely. Help me understand why that should fit in there.
I'll start, ma'am, and have our general counsel also. Obviously, anything that comes out of Mason Van Howling.
Give us your name, okay. I'm
Mason,
trying to help you,
I
Chair.
saw the looks. Mason Van Howling, for the record. Obviously, any CMS reports or findings, sentinel events, any penalties, any sanctions against any hospital is always public. So we would not try to take that and move it into some type of protected status or attorney-client privilege, if you will. So, but sometimes we will have findings that we need to talk about those in the closed session around patient care or something that maybe a public hospital missed, to include UMC. And so that's where we're talking about. If sometimes, say if it's a patient complaint, you have the right to report to a lot of agencies, and we've seen them all. State, local, CMS, Joint Commission, there's a lot of regulations. And so patients have venues to complain or file grievances through any venue. So should we have to take one of those into the closed session? But during the investigation period, they're either substantiated or not substantiated. So, and then once that's substantiated, it's usually released. So a lot of that's private between the investigator until they can get all the information. And so, but Ms. Pitts, I don't know if
I think that was sufficient.
Okay,
I mean, feel free to jump in, but I'd quit while you were ahead.
Okay,
and I said, I
yeah.
understand. So, no, thank you. That makes sense to me. Thank you very much.
Thank you.
Thank you, Chair.
Thank you. And within kind of, I think, the similar space, Assemblyman Ornlicker has some questions.
Thank you, Chair. Yeah, could I do a two-part? Okay, thank you. Thank you for the presentation. So I want to follow up first on Assemblywoman Taylor's on 3D, 1 and 2. So I appreciate why you can come up with examples of why closed session would be appropriate. But when you look at A and B and even the new C, they're written very narrowly. And D looks like anything, because, my gosh, anything could fit under all laws, regulations, and rulemaking, or any conditions of participation. It's hard to imagine what doesn't fit there. So while I can see that there are certain subsets of those, you haven't written it in terms of the kinds of situations, and it just kind of seems like it opens it up for anything you want to take into closed session, even if it doesn't fit in, the reasons why we have closed sessions. So why don't we start with that, and then I'll do my second one.
Okay, Susan Pitts, General Counsel for UMC. And thank you for the question, and I agree, and as you understand, I think very well, healthcare is very complex. We have healthcare on the federal level, healthcare on the state level. We have conditions of participation to participate in Medicare. Again, I do want to, one thing I was going to add with Mr. Van Howling's testimony was, this isn't just about lack of compliance, but actually compliance, making sure that we're able to, the reports that we give, our Patient Safety Quality Committee gives reports. They'll give those on an aggregate level a lot of times. It might be that the board has questions that they want to follow up from that, but we don't necessarily want to get into that information that might be more patient-specific, and so we'll want to go into closed session. So all of these matters, and we have tried to, over the time, narrow it and address all of these questions to make it really clear. We're trying to meet our requirements from Joint Commission, from CMS, to have these fully informed boards on all of the aspects of the hospital and all of the compliance that we need to do to make sure that we can participate in CMS programs and our licensure through the Department of Health and Human Services. So I think that's what you're getting to as to why it's broad. It's really healthcare compliance. I don't know. We don't always know specifically what might be an issue we want to have a fully informed board for, but the Joint Commission is going to require that we're able to show that we have informed them on all aspects of our healthcare compliance. So I hope that helps answer the question.
Thank you. And the other one on C, I understand why when your allegations about competence and character and you want to protect the reputation, what happens if, how is the public protected if there are legitimate complaints and sometimes they get covered up, right? We've seen, I don't know of any examples at UMC and hopefully we never will, but we hear regularly in other healthcare settings, hospitals, where people have an ongoing bad record and nothing's done, and this seems to, where's the protection if in the closed session they decide it's not substantiated? How is the public protected?
Susan Hitz, General Counsel for UMC, for the record. So one thing I'd like to add about subsection C is that there is the ability to go into closed session for these matters already under NRS 241 under the open meeting law. The issue and why we would like that clear in our own NRS 450 is so that there aren't conflicts. There are certain notice requirements that might differ. So when you talk about taking, unfortunately, if you have to take an action, if a medical staff, MEC has to take an action against a provider, they have rights. They have to get due process. We obviously make sure and we take care of that. They would receive all their due process. They would receive a fair hearing. If there's a final adjudication where they are a bad doctor, there is also federal law that requires for the National Practitioners Data Bank, where that is, those instances are put there so that they can't go from state to state. And that's what that legislation did back in, I believe it was 1986. So there are mechanisms to make sure on the federal level that bad providers can't go from state to state and things aren't put under the rug, so to speak, as you stated. For us specifically, if they were to go through that due process and say in here we're probably specifically talking about appeal that would go up to the governing board level, who has the delegation to hear appeals of these matters, they're not going to get a whole new hearing. And under 241, the language, how it was written, almost appeared to give them different rights and notice requirements in a new hearing. So we're trying to follow their due process. But if there was an action out of that appeal, say the provider's privileges, in fact, are going to be revoked, that is when we would come out of closed session and make that final action to revoke those privileges.
Follow up, please. I think I followed what happens when you find. I'm concerned about when you decide not to find. So you said there's previous proceedings. Would that cover that? As I said, I'm worried about the provider who's bringing in millions of dollars, and so nobody wants to touch that person and just gets no findings made. So there's nothing to report to anybody because you don't make the findings you should make.
Sure. Susan Pitts, General Counsel, for the record. So I think what you're talking about, the fair hearing I'm talking about with the medical staff, that doesn't involve the public board. So that's why I'm not specifically addressing that. So that would be the action of the peers, the peer review proceeding where they decide whether or not to take action. It's at the appeal of that decision that it would be heard by a public body.
And if I, sir, could also add, and I understand the question, and I've had the opportunity to work in all different parts of hospitals, for-profit, not-for-profit, public, military as well. And so the process is pretty much the same. There's a whole system of bylaws and rules and regulations, and as Ms. Pitts talked about due process, it's almost like a court. Fortunately, we don't have to sit in a lot of those, but there are times, I will tell you. And so I assure you that that process is sound, and the medical community really does regulate itself. They do not like to have these bad marks, and they don't like to have bad doctors working with them. But there's a process. So if there are times where the information may not, we may not have all the information, or the fair hearing does find that it doesn't level to a suspension or a report to the data bank or all the way up to the Nevada board here. So again, that process happens at UMC and every hospital that he represents and every hospital throughout the nation. Often what you see on some of the courtroom, TV room dramas with hospitals. But again, to get to your question, if that does happen, if it doesn't warrant a suspension or a report to the data bank, that matter is kind of a closed matter, or they go on some type of monitoring process, or they have a preceptor, oversight, those type of things that not everybody gets to see day to day, but I assure you it does happen. But if it does come, as Ms. Pitts mentioned, if it does come out of the governing board, that's a reportable action. And we've had to take that in the past at UMC.
And I think it's important to acknowledge like how many layers there are that are intended to protect the public from bad actors in the community, because the integrity of our medical community is very important to that trust relationship and privilege relationship that our doctors hold. And those include the Board of Medical Examiners, which they accept complaints. Law enforcement is in part can be a part of certain complaints, and then the local hospitals and places where those folks may be contracted or employed. There are several layers in place. It's not a one singular decision-making body that often is a part of those issues, and the discussion of what privileges those doctors can retain if there's a valid complaint, and what the process looks like. So I just wanted to put out there that it's not just within the hospital setting. There are other areas in which doctors are responsible for their actions as well. Like I said, I've gotten to explore some of the Board of Medical Examiners process over this session, and it's very interesting. Anyways. It's Friday.
And Chair Peters, if I could,
yes, please, go
we
ahead.
see that people coming into our state, but we also want to make sure that nobody's jumping from state to state. So it is a national data bank, and I've seen where doctors are trying to get on staff, and they have to explain what happened 5 years ago, 10 years ago, 20 years ago. So as you mentioned, we hold them to the highest standard, and I tell you, the medical community, their peers hold them. They really do ensure that they're delivering the highest quality care. So thank you for that.
Yeah, and there are some that slip through the cracks, but we're working on it together, right?
Yes.
To make sure that we have the right layers in place. Assemblywoman Thomas, I have you as my last question today. Please let me know if anyone has further questions before we move on.
Thank you, Madam Chair. And thank you for the presentation. I do appreciate it. And I'm glad UMC was out in front on this. I do appreciate renown, but UMC, I must say that I've had the pleasure of being a patient on more than one occasion, and I can tell you that I felt extremely privileged to have the amount of professional services, and that's even including in the ER. You know, unfortunately, I had to be transported there due to a horrific car accident that I had. And the service that I received there was exceptional, in my opinion. My question actually goes back to the dental. And I know you guys are probably beating this dead horse, but I look at it as, would this complete your to say wraparound services? Because I know that UMC has an excellent burn unit. I know that we have OB/GYN, you know, those services, mental health services, you know, a litany of things. Would this dental part of your business plan support the wraparound service that you are looking for?
Thank you for the question. Mason Van Houweling, CEO, UMC for the record. Appreciate the question, and I'll certainly convey your comments back to the team in Las Vegas. So thank you for your support. I wish I could say yes, this finally checks off the final piece, but as you know, UMC is home to a lot of firsts and onlys. You know, we just started doing our pancreas transplants, but we need to get into livers. There's a lot of things, liver transplants, there's a lot of things that we provide that others don't. And again, this will allow us an avenue to be able to do that under the corporate practice of dentistry. So there is more to come, but you know, this is a big step because, and I think it's a relatively small step that we can be able to fit in very quickly, but there's still, UMC is still addressing, we're looking at behavioral health issues. There's all kinds of things that we get approached to, especially after the pandemic, because what we were able to do during, you know, the vaccinations and the testing. And again, we collaborate with Renown quite a bit. We would love to see them grow and burn and transplant and level 1 trauma center. So we work very closely with them as well. They're very similar, as you know. So, but I wish I could say that would check off everything and the world problems would be solved, but there's probably more that you'll see us on the move for. Our online care, we're doing that now, so you can do visits from home. But so kind of a long answer to your question is we'll probably have more moves that we'll make, but not around this, hopefully. This will hopefully land this and package it in a way that we can have clarity.
And yes, thank you for that explanation. And I'll just, you know, this won't be a question, it'll be a comment. I do like the component of the dental care because we do have a homeless community out there. And I am so sure that they have been there, you know, complaining about their dental. They don't have health insurance. And there are a lot of people, you know, COVID has wiped out a lot of families. So we know that they are arriving at your doorstep. And I think this would be great. Thank you. Thank you, Chair.
Thank you. Other questions, folks? Before we move on, all right, we'll move into testimony. Thank you all so much. We will start with support testimony in our physical locations. For Senate Bill 192, if there's anyone who'd like to provide support testimony, please come up to the desk. Seeing no one in Carson City and no one in Las Vegas, we'll go to the phones. BPS, is there anyone on the phone line to provide support testimony on SB 192?
Thank you, Chair. There are no callers at this time.
Thank you. We'll move into opposition testimony. Is there anyone in the room who'd like to provide opposition testimony in Carson City or Las Vegas? Seeing none. BPS, is there anyone on the phone line for opposition testimony on SB 192?
Chair, there are no callers at this time.
Thank you so much. We'll move into neutral testimony. Is there anyone in Carson City or Las Vegas to provide neutral testimony? Seeing no one approaching the desk, BPS, check the phone lines for neutral testimony on Senate Bill 192.
Chair, there are no callers to provide testimony at this time.
All right, well, that wraps up testimony. Would you like to provide any closing remarks? Closing remarks? Nope, we're waiving closing remarks, so I will close the hearing on Senate Bill 192 and move on to the last item on our agenda today, which is public comment. If there's anyone in our physical locations for public comment, please come up to the desk. We are asking that people limit their public comment to 2 minutes to afford fairness in the public comment process. You may also provide public comment in writing. I'm seeing nobody in Carson City or Las Vegas. BPS, would you check the public line for public comment today?
Chair, the lines are open and working, but there are no callers at this time.
All right, well, that brings us to the end of our last agenda item today. We will have committee on Monday. I hope you all have a wonderful weekend celebrating the mothers in your life, be it dog mothers, cat mothers, folks who are the mothers in our lives, regardless of their biological attachment to us. And we will see you bright and early Monday. We are adjourned.